Systemic lupus erythematosus, SLE. The skin manifestations of SLE include malar erythema, manifested by slightly indurated erythematous patches on the face in a butterfly configuration, as well as erythematous patches and annular plaques on trunk and upper extremities. Occasionally SLE shows urticarial, purpuric, ulcerated or bullous lesions. Vasculitis is also a manifestation of SLE. Discoid lesions can be seen occasionally. Late manifestations of SLE include poikiloderma, vascular atrophicanes, malar rash, discoid rash, photosensitivity, oral ulcers, arthritis, serositis, pleurisy or pericarditis, renal disorder, neurologic disorder, seizures or psychosis, hematologic disorder, anemia, leukopenia, thrombocytopenia, immunologic disorder, positive LA, anti-DNA, abnormal titer, antibody to SM nuclear antigen, positive test for syphilis, abnormal ANA titer. Systemic lupus erythematosus. The histologic findings are those of poikilodermatous dermatitis with eosinophilic, thick subbasal membrane zone. In general, a diagnosis of SLE can be established when there are 3 of the following 4 signs: cutaneous eruption consistent with renal involvement, serositis, and joint in SLE is usually characterized by a poikilodermatous dermatitis with a sparse lymphocytic infiltrate. There is thickening of the basal membrane zone by deposition of an eosinophilic, homogeneous and sometimes fibrinoid material. There is also mucin deposition throughout the dermis, seen as bluish material between the collagen bundles, a very characteristic finding in lupus erythematosus. The dermis itself may show bluish, purpuric, ischemic-like areas. Focal extravasation of red blood cells in the upper dermis may be seen. In contrast to discoid lupus erythematosus, the lymphocytic infiltrate is rather discrete in SLE, particularly since there is absence of the patchy perivascular and periadnexal infiltrate seen in the chronic cutaneous form bullous lupus erythematosus. There is a prominent neutrophilic infiltrate, with nuclear dust in the papillary dermis, adjacent to the dermo-epidermal junction and sometimes trekking along the basal layer of the epithelium of hair follicles. Bulla formation ensues. Other areas of the biopsy may show characteristic findings of lupus erythematosus, Fig. 6.5. Immunofluorescence. The lupus band test is positive in 90% of involved skin and in 80% of non-involved sun-exposed skin, usually volar aspect of arm, of patients with SLE. Of diagnostic importance is the lupus band test from uninvolved sun-protected skin, usually buttocks, in which a positive lupus band test often implies active renal disease. The lupus band test is demonstrated with direct immunofluorescence, and it is characterized by a continuous granular line or band along the dermo-epidermal junction, either with Ig alone, or Ig and IgM, as well as C3 laboratory abnormalities. The most sensitive test is the ANA, although it is not specific for SLE. Anti-nuclear antibodies found in SLE include antinative DNA, anti-double-stranded DNA, anti-nucleoprotein antibodies, anti-SM, Smith, antigen, anti-ssDNA antibodies and anti-NRNP antibodies. SM antibodies are indicative of significant renal involvement. Anti-cytoplasmic antibodies RO-SSA antigen and LA-SSB antigen are often found in patients with subacute cutaneous SCLE. Other laboratory abnormalities include hemolytic anemia, leukopenia, lymphopenia, and hypocomplementemia.